Hello and welcome back. So this is the fifth part of lecture on fibroids. We are discussing different management options. Just a quick revision. So in medical treatment for abnormal uterine bleeding, yes, I have not mentioned them here, but we can use tranexamic acid and rest of the medications given in a previous part of the lecture. Then preoperatively, to reduce the risk of hysterectomy and myomectomy, we can give these two GnRH agonists or selective progesterone receptor modulator. Then in surgical treatment, it depends where is the fibroid located and are they causing any symptoms or not. Okay, so for example, if it is a submucosal fibroid only, it can be removed hysteroscopically, so it will be hysteroscopic myomectomy. But if it is present inside the wall of the uterus or subserosal, and if they are causing symptoms, depending on whether the patient wants to preserve her fertility or not, she can be offered myomectomy, which means just simply remove the fibroid, leaving behind the uterus. Or if she's done with her family, right, and if she does not want to have a myomectomy, or especially if she's closer to the age of menopause, she can have a hysterectomy, okay, if it is causing symptoms. Okay, then these procedures can be performed laparoscopically or open, okay, both of them, myomectomy or hysterectomy. Yes, hysteroscopy we already talked about. Sometimes less common procedures, which are usually, I don't think in the UAE we have any of these procedures, but they can be frozen. They reduce them to a very cold temperature. That shrinks the fibroids. That cryomyolysis, that kind of destroys the smooth muscle. Or thermocoagulation, like either heat or cold, apply heat or cold. Okay, but unfortunately in the UAE, in my information, these procedures, these two last two, they are not performed. Now, we have at some hospitals we have this procedure performed, which is called uterine artery embolization. Maybe I told you that it's not performed by the gynecologist; it's performed by interventional radiologist. Okay, the procedure name is UAE, uterine artery embolization. Okay, at some hospitals we do have this procedure. Then, unfortunately, in most of the hospitals, in my information, this second procedure, magnetic resonance guided focused ultrasound surgery, this is not performed. Okay, but this is an option if there is facility. This is non-surgical, right? This is just MRI guided, like from the, I will have a slide there. So, what are the surgical management? First, we have to always which option suits which patient, okay? And we have to discuss, a patient may have two, three options, right? And we have to discuss each and every option, discuss the side effect, discuss the benefit, and she can choose, okay? So, what are the indications of going to surgery? First is medical treatment has failed, so that means at least for 3 months. Like if we used, say, for example, Myrina, for example, right? Or say, for example, if we used, say, tranexamic acid, and if it failed, then that means for 3 months, then that's considered a failed medical treatment. Then the symptoms, the fibroid should be symptomatic. Do not treat asymptomatic fibroids. Okay, so that's the rule. That's why I have it's in capital letters. And the patient depending on if she wants to have more children, desire for future fertility or not, right? So then, but again, it makes a lot of difference, because if we want to preserve her fertility, then it should be myomectomy or hysteroscopic polypectomy. Otherwise, like hysterectomy is an option. Or there are some other procedures which we are going to discuss, which includes endometrial ablation. Endometrial ablation is not for big fibroids. It's not for intramural or subserosal fibroids. Okay, so it's only for submucosal fibroids, which are very small, which are less than 3 centimeter, and the uterus should not be too big. Okay, so there are different methods which are used. One of them, there are like the devices used, their first generation, which were the initial ones. One of them was transcervical resection of endometrium, and then more advanced devices are produced, and one of the famous one is called Nova Shore. Okay, so this device is inserted inside the uterus, and it destroys the endometrium. Okay, so imagine if there are small, big fibroids, of course, a lot of endometrium will be left behind. So even with small fibroids, it may not be as good as when there are no fibroids. Okay, so it causes 40% of patients, it causes absence of periods, but 20% fail. Okay, so patients will have again heavy bleeding or whatever symptoms they had. Important is, do not offer endometrial ablation to a patient who desires future fertility. Okay, because it destroys endometrium, and implantation of the embryo happens in the endometrium. Okay, so but she needs to continue contraception in the future. Why? Because some endometrium may be left behind, right? And in the case that if endometrium, a little bit of endometrium is left behind, and if she gets pregnant, there are more chances of going into preterm labor and placenta previa and also miscarriage. Okay, so sometimes there may be a lot of fibroids, right? So there may be even a combination of intramural, subserosal, submucosal. So some patients, they can even have 30, 40 fibroids. So this, all of this is from just one patient. Okay, sometimes if a patient has a lot of fibroids, then just imagine doing a surgery, right? You cannot remove all of these seedlings. How many cuts will you give? Like, it will be try usually at myomectomy, it is ideal to give minimum number of incisions, right? But it depends on the position of the fibroids. So sometimes, especially if the patient is done with her fertility, she does not want children in the future, this procedure, uterine artery embolization, can be performed. This is especially for women who have multiple fibroids like this. Okay, and she's done with her family. Okay, so what actually the interventional radiologist does is insert some they infuse some these contrast particles into the femoral artery, and then they ultimately go to the uterine arteries, and then they block it. Okay, they reduce the blood flow. Okay, so they kind of embolize it. Okay, so embolization of both arteries under radiological guidance, and through the femoral artery. Now it causes shrinkage of the uterine fibroids by 50%. Okay, and after the patient, the interventional radiologist perform this procedure, the patient comes under gynae care. So she will be admitted in a gynae ward. The gynecologist will be taking care of her for post-op care. Okay. So, and then they can have this side effect, which is called post-embolization syndrome. It's quite common. So, how do patients present? They may have fever, they may present with infection, and a lot of pain. Okay, so, and because it can also compromise blood flow to the ovaries, so there is risk of having early menopause. So the age of menopause may be brought forward. Okay, and one third of women require further treatment within 5 years. So, and of course it can fail, right? So then ultimately women may end up having a hysterectomy. Okay, so now a few slides about myomectomy. Myomectomy was, there's a very famous person, his name was Victor Bonis. He has devised this procedure. So before him, myomectomy was not introduced. He even devised different methods to reduce, devices to reduce the amount of blood at the time of myomectomy. Okay, so we have this device, myoma screw, on the campus. When you come back, I'll show, and why he was so passionate about preserving for uterus in women with fibroids, because his own wife, who was a nurse, she had a lot of fibroids, and at that time, because myomectomy was not introduced, so she ended up having a hysterectomy without having any children, and he was affected by his own experience. So he devised, he's kind of a pioneer in gynae. Okay, so myomectomy treat fibroids only if symptomatic. Okay, and what can be the possible symptoms? They can cause infertility, heavy menstrual bleeding, or pressure symptoms. Okay, myomectomy preserves fertility, but there is small risk of having hysterectomy. It depends on the number and size of and location of the fibroids. Risk of having intraoperative bleeding. It can be performed laparoscopic, but if after laparoscopic myomectomy the patient becomes pregnant, there is increased risk of uterine rupture in the future pregnancy. We have another lecture on uterine rupture, so don't worry about this for the time being. And then if a patient has submucosal fibroid, then of course like this, so just remove hysteroscopically. If there are subserosal or intramural, then remove them laparoscopically, but remember they should be symptomatic. Okay. Hysterectomy can be performed again laparoscopically or open. Okay, open if especially if they're very large fibroids, and usually it is total hysterectomy. Total means you have to remove this cervix as well. Okay. So for postpartum hemorrhage, when it is performed, it is subtotal hysterectomy, which means leave the cervix but remove the body of the uterus only. Now, this is the MRI guided focused ultrasound. Unfortunately, in UAE, in my knowledge, we do not have it, but it represents a minimally invasive treatment for uterine fibroids that is able to improve the quality of life in fibroids size with durability. So, patient does not need to go to the operation theater, right? I mean, it's not, there is no cut on patient's abdomen. Okay. So that's it, and we will discuss these case scenarios. Think about these, and then we will discuss when you come back to the campus.